This is a presentation over the Depression, Anxiety, and Stress Scale by Courtney Bussmann and Denise Hazen with Colorado Christian University.
Introduction. For this presentation, Denise and I will look at the Depression, Anxiety, and Stress Scale that is also known as the DASS for short. Denise and I will alternate with each slide, and she will start with talking about the creation and implementation of this assessment. I will then look at its validity and reliability. Then, the populations that the DASS serves will be next, followed by a brief discussion of this assessment's follow-up reporting. The strengths and weaknesses of the DASS will be looked at, as well as the theoretical approach that best aligns with this assessment. Denise will then talk about what was confusing about the literature surrounding the DASS, and I will conclude with what we learned about it.
The DASS assessment is a self-report instrument, and questions can be completed in session within 3 to 10 minutes. Each question relates to a negative emotion and is rated on a 4-point Likert scale relating to the severity or frequency of the client's experience. It was created by researchers at the University of South Wales in Australia. There's the original 42-point scale or the shorter 21-point scale, both of which have been shown to be valid and reliable. The DASS 21 addresses 7 points per scale. Each item on the report measures depression, anxiety, or stress symptoms, as well as subscales for each. The main purpose for using this assessment is to determine the severity of the core symptoms of depression, anxiety, and stress. However, it does not measure all symptoms of these conditions, including suicidal ideation, which should always be assessed by the clinician. There are also no direct correlations between the scores on the DASS and the DSM or ICD. But the discerning clinician should be able to use results from the DASS to corroborate a diagnostic claim, or when trying to discriminate between symptoms of depression and anxiety. The depression scale correlates with mood disorders, the anxiety scale with various anxiety disorders, excluding generalized anxiety disorder, which actually correlates closely with the stress scale. The subscales assessed by the depression scale are dysphoria, hopelessness, devaluation of life, self-deprecation, lack of interest, among others. The anxiety scale evaluates autonomic arousal, skeletal muscle effects, situational anxiety, and subjective anxiety responses. The stress scale assesses levels of chronic nonspecific arousal, such as difficulty relaxing, nervous arousal, and being easily upset and impatient. The long and short version of the assessment are public domain and may be downloaded for free at the University of South Wales website listed on the last slide.
Validity and reliability. The validity and reliability of the DASS is an important element because it ascertains how viable this assessment is in practice. Sabo found that the DASS is able to also encompass the emotional experience of worrying, which makes this test have an even more comprehensive approach of the test taker's psychological world. For reliability, Cronbach's alpha is a standard in which many assessments are measured with. It is found that reliability is acceptable for the 3 scales used with this way of measurement, and it is true for both clinical and non-clinical samples. For validity, the full version of the DASS, as well as the short form, the DASS 21, both prove to have good validity. This is particularly true when it is compared to other ways of measuring depression and anxiety. Therefore, the DASS is both a reliable and valid measure.
For populations, the DASS has been translated into 48 different languages, but not all translations have been tested for validity and reliability. It is suitable for individuals ages 14 and up, although development samples were conducted on individuals age 17 and up. It is necessary to use clinical judgment to determine the appropriateness of this instrument with your adolescent clients. The measure has been shown to be valid for any population as long as the individual being assessed is able to understand the questions and has the ability to remain unbiased. It is not valid for individuals younger than 14, those who may have a low literacy ability, inebriated individuals, or anyone else that the clinician feels would not be able to adequately respond to the measure. While the DASS has been translated into many languages, cultural factors may still influence the validity of the measure. Particularly with Asian cultures, the stress scale may not provide adequate responses due to stress being expressed somewhat differently. In a study for the validity of the DASS in Asian countries, the questions, "I found it difficult to relax," "I found myself getting agitated," and "I felt that I was using a lot of nervous energy," were removed for that reason.
Follow-up reporting. In terms of follow-up reporting, there is no reporting that is officially required with this type of assessment. There are also no specific questions that directly address suicide abuse or that requires a mandated reporting by a counselor. Yet there are a couple questions in the assessment that the counselor should follow up on with the client in relation to a more severe depression. The two statements in the assessment are, I felt I wasn't worth much as a person, and I felt that life was meaningless. While both of these statements do not immediately address suicidal thoughts, they often are what the client may think when he or she is experiencing suicidal ideations. While all mental health professionals are trained to know the seriousness of this, it can also always be said again how important it is to follow up with the client who's experiencing these thoughts and to determine what is laying beneath them.
The strengths and weaknesses of the assessment. The full version of the DASS has more reliable scores than the shorter 21 version in clinical studies. It provides more information about a client's symptoms, which shows that it might be best for clinical work. The shorter 21 question version of the DASS can be completed in half the time, and many studies show that it gives similar results to the full version. So it may be best for research work because it takes less time to complete, yet still covers all the subscales of depression, anxiety, and stress that are covered in the longer version. To score and compare the DASS 21 to normative data, you would just double the score. It has been proven through many studies that it is reliable and valid as compared to population means. It also has the added benefit of omitting items that have been identified as problematic in the full version.
Theory in the DASS. There is no distinct theory that this assessment is officially paired with, or that this assessment stemmed out of. Yet, the best theories that work with the DASS are the ones that address the areas of depression and anxiety, with stress being combined with anxiety for the purpose of matching up this assessment with a theoretical approach. This leads us to behavioral and cognitive theories, as current treatments for anxiety and depression almost always include behavioral and cognitive treatments, with the focus on the behavioral side, according to Bussmann and Jones. For behavior theory, a driving thought behind it is that human survival is the driving motivation behind our behavior. This brings us to DBT, dialectical behavior theory, as it is a common approach used for depression. Within DBT, emotional regulation and distress tolerance are addressed, which are some of the core needs for those who rank on the DASS. For cognitive behavioral theory, thoughts are the powerful determining factor of behavior, and that includes depressive, anxious, or stress behaviors. REBT, rational emotive behavioral theory, falls under this theoretical umbrella with the ABCDE model that concludes thoughts are central to understanding the person. CBT, cognitive behavioral theory, addresses the person's beliefs with thought records and automatic beliefs. Hence, behavior and cognitive theories both complement the treatment for issues that the DASS may reveal in a client.
So what was confusing in the literature? There is plenty of research providing information on the validity and reliability of the DASS measurement. However, it was difficult to find any correlation to the use of the DASS to a particular theoretical approach. Rather, as Courtney just showed, we were able to infer which theories would best connect with this measure by researching which have been proven to work best with depression, anxiety, and distress. The manual, which is available for purchase, provides the score breakdown into normal, moderate, and severe labels. These are also available through web searches, but the application of the DASS results to clinical work should be determined by the clinician in conjunction with the clinical interview. And then the research that is available is descriptive, and information is available on the various studies that have been done across cultures for the validity of the DASS assessment. These research studies will hopefully be less confusing to dissect once we complete our research and evaluation course. For now, the discussion portions provide the breakdown information confirming the validity and reliability of the DASS 42 and the DASS 21.
Conclusion, what we learned. We learned how the DASS is an effective assessment tool for the short and long forms, and that both versions of this assessment are considered to be valid and reliable. We also learned that the short and long versions of the DASS both cover the 3 scales of depression, anxiety, and stress. And as a result, not one area of the assessment is diminished or disregarded with the shortened version. Most importantly, we learned that the DASS is one of the few assessment tools that can reliably separate the questioning on depression and anxiety, which the two are often combined and difficult to individualize in assessments. From the Christian counseling perspective, the DASS brings up issues that God has an answer for. He tells us to cast our anxieties on Him because He cares for us in 1 Peter 5:7. As counselors who lead clients out of their cycles of depression, anxiety, and stress, we can also be comforted in knowing that we can find peace through our source in Christ.
And here are our references. Thank you for your attention.